We begin this morning with three presentations related to stone disease. The first is James Lingeman. He's going to present on randomized controlled trial of treatment of asymptomatic small renal stones at the time of symptomatic stone removal. He'll be followed by Dr. Mahesh Desai from India. His title is A New Curiosity in Treating Renal Stone, High-Powered Holmium with Moses Technology, or a Thulium Fibre Laser in Miniperc with suction. Finally, in this hour, we'll have Prokar Dasgupta, a new member from UK. He will be talking about the simulation in urological training and education, Simulate, a randomized controlled clinical and educational trial to determine the effect of simulated base surgical training. It'll be followed by a discussion period.
Dr. Flanagan, Dr. Badlani, members and guests. I'd like to share with you today our work in a randomized controlled trial looking at relapse rates between standard ureteroscopic ureteral stone removal and ureteroscopic stone removal combined with clearing of asymptomatic renal calculi. This work has been supported by the National Institutes of Health. We're very thankful for their support. The treatment of asymptomatic stones, as many of you know, is controversial. There have been many publications over the years. Interestingly, there have been 3 in just the last couple of months giving mixed opinions about the utility of treating asymptomatic stones. There are, however, no prospective studies addressing this issue. An additional issue in this whole topic is the fact that our CPT codes for ureteroscopy are ancient and predate our ability to work in the kidney with flexible ureteroscopes, lasers, sheaths, etc. Now, a number of authors have reported that it is indeed feasible. We all know this, of course, to treat ureteral stones and concomitantly treat renal stones. All of the publications show that there is no increased morbidity to the treatment of both renal and ureteral stones. These are retrospective studies. As we would expect, there are longer operative times when you're treating more stones, and we don't have any long-term data on these patients. So we put together this study to test the hypothesis that removal of asymptomatic stones from the kidneys of patients being treated for ureteral stones will reduce the recurrence of stone events in subsequent years. The principal investigators for this project were myself, Matt Sorensen at the VA in Seattle, Jonathan Harper at the University of Washington, and Mike Borofsky at the University of Minnesota. We used standard protocols per HPI's practice. We're all pretty similar in the way we handle things. When a patient randomized to treatment of the renal stones, we made an effort to clean the kidney out as thoroughly as possible. All patients were offered our standard dietary and fluid protocols as well as metabolic evaluations. These were recurrent stone formers. Stones were analyzed both by micro-CT by Dr. Williams of our research group and also by FTIR. Inclusion criteria included patients scheduled to undergo ureteroscopy or percutaneous removal of stones that were visible on KUB. So we focused on calcium stones in this study. They had to have a current CT scan within 90 days of the procedure and a history of recurrent stones. Then they needed to have asymptomatic ipsilateral or contralateral stones, and they needed to be of age and able to consent, of course. Exclusion criteria were stones that were radiopaque, history of non-calcium stones, such as cystine and such, and patients with systemic diseases were excluded, RTA, hyperpara, sarcoid, enterics, and sponge. Follow-up comprised a low-dose CT within 90 days of treatment to reset the baseline for the patient. Patients were contacted every 3 months for follow-up histories about ER visits, procedures, stone passage, etc. All patients had a low-dose renal CT annually for up to 5 years. These are special studies, so they're a focused exam, low dose of the kidneys only. The radiation dose is comparable to that of a KUB. All the scans were reviewed by, or are being reviewed by, a referee radiologist. We've had issues with data sharing agreements with the VA, but that's finally resolved, and that data is being analyzed currently, so I don't have it for today. We randomized 73 patients. One patient died in each group during follow-up due to non-urologic causes. 4 subjects withdrew from the treatment arm and 5 from the control group, typically because they didn't randomize to the treatment that they wanted. All data were included up to the point of death, withdrawal, or loss of contact with the subject. We lost contact with only 1 subject in each arm, so we did pretty well with follow-up. Looking at the demographics and clinical characteristics, as we would expect from randomization, the groups were very equal. As you can see, the stones were almost all calcium oxalate. The uric acid stone was actually a mixed stone, and it was radiopaque. Not surprisingly, the surgical procedure took about a half-hour longer in the treatment arm. This is consistent with the published literature that I cited earlier. This is the money slide, so I want to spend some time on it. What we did here, our primary outcome was looking at the need for additional stone procedures or emergency room visits. We did exclude ER visits from the first couple of weeks after the procedure. These were all patients that had stent symptoms that resolved with removal of the stent. But what you can see here, we've divided it up by subjects and events. So what that means is that a subject could have more than one event. So the counts are going to be a little different. And you can see that in the treatment arms, there were very few additional procedures or ER visits. In the control arm, 9 patients of the 35 needed an additional surgical procedure. 18 patients had emergency room visits. Some patients had more than 1 ER visit. So that means that a total of 27 of 35 patients in the control arm had additional significant outcome events during follow-up for the trial, as opposed to 3 of 38. Patients were noted to have a spontaneous stone passage without requiring treatment. They were pretty much the same in each group. These are the survival curves for the treatment and control group. This was a highly significant number, as you can see. So this study provides the first high-level evidence that the treatment of asymptomatic stones in the kidney present at the time of a ureteral stone event confers significant benefit to the patient in reducing future stone events. Based on this data, we should have the AUA consider updating the ureteroscopy codes to be more realistic, reflecting the increased time and effort required given the current modern era with flexible ureteroscopes and lasers. Just as an example here, you all probably know this data, but the ureteroscopy codes really are pitiful and not at all reflective of the hours that some of us spend looking through flexible ureteroscopes cleaning out kidneys. You can bill for a renal and ureteral stone during ureteroscopy, but the insurance companies don't pay for it. So in conclusion, removing asymptomatic stones at the time of ureteroscopy reduces stone growth and return visits to the emergency room and surgeries. Based on these results, we would recommend treatment of even asymptomatic kidney stones, at least on the same side during ureteroscopy for a ureteral stone. Based on the high rate of intervention in the control group, we would suggest consideration of early intervention. And I thank you for your attention.
President Bob Flanagan and Vice President Gopal Badlani, thank you very much for giving me this opportunity. I'm going to speak on a high-power Holmium with Moses technology and comparing with Thulium Fibre Laser in a Miniperc with suction. New curiosity. The Miniperc is gaining popularity for a treatment of medium to large renal stone. While the mini PCNL may reduce bleeding complication and morbidity, it may be associated with less efficient stone extraction and longer procedure time. Integration of active suction during mini PCNL reported as a super Miniperc may allow simultaneous aspiration of dust during the lithotripsy and a small fragment after completion of lithotripsy, leading to a potential improvement in stone clearance and the procedure efficiency. The present initial clinical comparison between the high-power Holmium and the Thulium during the mini PCNL for renal calculi, with specific emphasis on a fragment efficiency, fragment size distribution, and stone-free rate. Reaching a total stone-free rate in the kidney with one treatment episode remains a challenge for a conventional mini PCNL procedure, especially for the stone 1 to 3 centimeter in size. Even with newer advances in PCNL, migration of small fragments produced with the laser lithotripsy remains a concern, may result in incomplete clearance. In June 2020 to December 2020, we performed mini PCNL for renal calculi less than 3 centimeter using either Moses Holmium or Thulium. Data was collected prospectively in our institutional stone registry. Stone fragments were retrieved and segregated to assess the proportion of dust less than 1 millimeter, small 1 to 3 millimeter, and large more than 3 millimeter fragment. We use 18 French Super Perc sheet and an 18 French Cleopatra sheet. It has got a special design where it can use a suction, and here you can see this is an oblique suction which can suck out all the fragment. Here is a vertical suction and which can suck out all. Now here you can use your thumb here or here to increase or decrease the amount of suction you require. If the fragment is large, we can bring the telescope right up to the red line so that suction fragment will be sucked out, and we use a 12 French nephroscope. And then what the fragments we get, we divide them into 3 different groups, as I said earlier. And then how it is done. So we use a 18 French the nephroscope, that is 5.94 millimeter, and 12 French telescope. So you have a free space of about 6 French, that is 1.98 millimeter. So all the dust will be sucked out. At the same time, up to fragment up to 2 millimeter can be also sucked out. A larger fragment can get stuck here, where you can withdraw the telescope and the whole fragment up to the 6 millimeter can be sucked out, and you can bring the telescope up to red line, and so that this fragment will go down. And then we use a Moses laser machine and a Thulium. Moses is 120 watt high power laser, while this is a 60 watt. And we use a 365 micron laser fiber in Moses, while 400 micron laser fiber in Thulium. Now this is just to show you the suction device, which is very important. Here we can withdraw the telescope and bring it up to the red line, where the larger fragment can be sucked out, and all this fragment can go collected into a jar, and which can settle at the bottom, and then afterward we can take it out, as you see here. And then once we have all this the stone, we dry them, and then we sieve them, and then we make sure that we segregate 3 millimeter, 1 to 3 millimeter, and the dust separately. And we also weigh them to know how much it weighs. And this is how we divide all the fragment which is sucked out into a different size. So the preoperative criteria: patient more than 18 years, renal stone between 1 and 3 centimeter in size, identified on the CT scan, normal upper tract anatomy, BMI less than 35. The exclusion criteria, of course, is a comorbidity, a blood thinner, untreated culture, or a positive UTI, pregnant or nursing woman, or a urethral stricture. The endpoint, the primary outcome, was the stone-free rate as estimated by the absence of any fragment on a non-contrast CT scan obtained within 48 hours or 1 month. CT scan is important. Secondary outcome were the stone fragment rate, lasing time, operating time, total energy, stone fragment distribution, and a perioperative complication. Lasing time was defined as the total duration of laser usage, while operating time was defined as the time for a cystoscopy to exit. stone fragmentation rate was calculated by dividing the stone volume by the lasing time. To our best of our knowledge, this is only one in vitro study comparing Holmium laser with the Moses effect on thulium. We here report the first clinical comparison of a high-power Holmium laser with Moses technology versus thulium laser fiber lithotripsy in a mini-PCNL with a special focus on stone clearance, distribution of fragment size, and fragment efficiency. This is a statistical analysis, which is a two-tailed t-test or a chi-square or a Fisher extract test for a categorical variable with a two-tailed p-value of less than 0.5 being significant. Now here we have kept the laser setting according to the stone household unit less than 1,000, 1,000 and 1,400 and more than 1,400. Now this amount of setting which we decided, the power is same and the setting is a variable between the two depending upon our previous study which is on a Moses and thulium, which we have published in a journal regarding thulium. And according to that, we decided the setting on the laser machine. For example, this is a two stone which is shown, which are almost similar. And here we have done 0.5 and 60 frequency millijoules, and for a Moses is a 0.1 and 200 frequency. In Moses, we increase the power, while in thulium we increase the frequency depending upon how the fragment is breaking. Most important, what we found is that not only the household unit, but how the stone is structured. If it is a porous stone, then the stone will fragment into the small fragments. But if it is a solid stone, then you can get more dust. And then we will we'll categorize the dust into 3 different sizes between the Moses and laser. And most importantly, after 48 hours, we'll have a CT scan to prove that the patient has a stone-free status or not. Here, all the baseline parameters are statistically comparable since the p-value is greater than 0.05. From the outcome variables, we can say there is a statistically significant difference in operating time and percentage of stone fragment size between 1 and 3 millimeter between Holmium and thulium. Clinically, we can say that more dust obtained in thulium as compared to the Holmium, which is 50.20% in thulium, while 43.56% in Holmium. The average stone volume and operating time are statistically significant in both laser for a soft stone, while in hard stone, only the operating time is statistically significant in both laser. Clinically, for a hard stone, we can say that the Holmium is good as compared to the thulium because energy required, total laser time required of obtained percent large fragment are lesser with the stone free rate and fragment size as a dust is greater as compared to the thulium. Now, stone free rate at 48 hours were with the Moses was 23 out of 25, that is 92%, while at 1 month it was 96%, 24 out of 25. While with thulium, it was 22 out of 25, that is 88%, while at 1 month, it was 23 out of 25, that is 92%. And the stone size, if you see the fragment which were left behind, their size was 5.36 and 4.6 was maximum. Now, I think these are the chips which comes out at the periphery. So if you have to improve your technique to make sure that you don't get a chip, you can get a dust. So in conclusion, the initial clinical comparison of high power Moses and thulium showed a similar stone free rate. Stone free rate in 1 month was 96% in Holmium and 92% in thulium group. Furthermore, within constraint of the laser fiber size and energy setting, both modalities were equivalent in terms of fragment efficiency and proportion of dusting across the stone density. Further clinical comparison data are awaited. Thank you.
This is Prokar Dasgupta bringing you greetings from King's Health Partners in London. Thank you so much for welcoming me into the AAGUS family. It is my great pleasure to present to you the outcomes of the first international randomized control trial of surgical simulation called the SIMULATE study. We set out to answer two important questions. Firstly, whether simulation creates better surgeons, and second, whether it has better patient outcomes. We used to call this predictive validity in the past. We all know that there have been significant changes in the training of residents, less time, more demands, and so on. In the background of this, the majority of simulation studies thus far have been aimed at medical students, and therefore there's a lack of level 1 evidence. The aims of the SIMULATE study was to evaluate if supplementary simulation-based training led to better proficiency. Second, to see if simulation-based training directly impacted on patient outcomes. And finally, to evaluate the educational value of such a training curriculum. Let me take you through the trial design. This is a randomized control trial across 18 centers in the UK, Europe, China, Japan, United States, and Canada. The sample size for 90% power was 48, and these needed to be residents with less than 10 index procedures having been performed and no prior simulation experience. We recruited 94 residents and block randomized them into the simulation-based training arm and the non-simulation-based training arm, while supervised OR training continued as standard of care. The follow-up was by OSATs, which stands for Objective Structured Assessment of Technical Skills, and the trainees were followed up for 25 procedures or 18 months. The primary outcome was the number of procedures to proficiency, which was clearly defined as 3 consecutive operations with OSATs of greater than equal to 28 without postoperative complications. The secondary outcomes were complication rates, OSAT scores, and educational value. The index procedure was debated in Bowes Council, and we decided that ureteroscopy was an operation that every resident needed to learn. The others in the frame were TURP and laparoscopic nephrectomy. The curriculum was developed by a 2-round Delphi study, and then the intervention was didactic lectures followed by training in a virtual reality simulator or in a dry lab or a cadaveric lab, depending on availability at the local center. We also put the residents and their teams in a full immersion igloo to record non-technical skills. Here are the demographics. 65 residents completed the trial and had operated on over 1,000 patients. You will notice that in the simulation-based training arm and the non-simulation-based training arm, hardly any of these residents had any experience of prior ureteroscopy. Here is the primary outcome measure, which, as I mentioned, was very clearly defined proficiency. In the x-axis, you will see the number of procedures to proficiency, and on the y-axis, the percentage of trainees reaching proficiency. In red, you have the simulation-based training arm. In blue, the non-simulation-based training arm. And you will see that the sim trainees achieved proficiency earlier than those in the non-simulation-based training arm. However, this was not statistically significant except for flexible ureteroscopy, the more complex form of the procedure. Here are the secondary outcomes, starting with the total OSAT scores. In gray, you have the sim arm, In blue, you have the non-SIM arm, and these are the tail graphs. On the x-axis, you have the various domains such as respect for tissue or instrument handling, and on the y-axis, you have the domain score. The higher the score on the y-axis, the better the performance of the residents. And you will notice that across the board, the simulation arm performs better than the non-simulation arm. Indeed, 66% of trainees in the sim arm achieve proficiency as opposed to 55% in the non-sim arm. Now, does all this matter to patients? Here are the complications. Each of the dots on this frequency dot plot is a complication, and you will notice that the residents in the sim arm, which is below the x-axis, had fewer complications than those in the non-sim arm. Indeed, it was 2.5% in the sim arm and 6.8% in the non-sim arm. Also, grade 3 injuries occurred more in the non-sim arm as compared to sim arm. One of the examples is the grade of ureteric injury, 9 in the non-simulation arm versus only 3 in the simulation arm. Here is the educational value of this intervention. On the x-axis, you have what is called the Likert score, which goes from 0 to 5. The higher the score, the better the educational value. And on the y-axis, you have various domains such as simulation training is essential for patient safety. Simulation has significantly improved my skills. And this was scored by each of the residents participating in the trial. You will see that we scored over 4 in all the domains where we tried to assess the trainee's educational value. In conclusion, although we have shown no statistically significant difference in proficiency except in the more complex form of the procedure, more residents have reached proficiency in the sim versus the non-sim arm, and the trial has shown for the first time that there are less number of overall and serious complications, which matters to patients. The educational value of simulation in this trial was excellent. I must thank our funder, which was the Urology Foundation and the Medical Research Council UK Centre for Transplantation, our trainees, and the 18 sites which participated in this trial. Thank you so much.